And as Dr. Carter talked about and Dr. Van Buskirk mentioned, you really first want to rule out serious illness, injury, especially if there's loss of consciousness or the presence of post-traumatic amnesia. Those would be indications perhaps to go to the emergency room. Not everybody needs a head CT that goes to the ER. There are guidelines for emergency personnel and physicians as to who should get CTs or not, but it's often done. Major concerning symptoms would be the alterations in consciousness, neck pain, a biggie, and you heard Dr. Van Buskirk talk about the two individuals, or I think two individuals that had neck problems that fortunately were recognized, but often may not be recognized. And then any, of course, loss of sensation or abnormal posturing. So the history has also been alluded to. You want to know if there are prior concussions or recent concussions, any other neurological or psychological issues. In brain injury, if you have a history of depression, you're undoubtedly going to have either more depression or severe depression if the symptoms linger. There's good data published in 2010 in the in the Journal of the American Medical Association that suggested that. There's also a history of headaches or migraines, not uncommon, needless to say, and often exacerbation of those headaches could occur. There may be other major history items that you may or may not know as the evaluating practitioner. Again, loss of consciousness, and Dr. Van Buskirk mentioned getting a good history is critical, or the presence of that amnesia. Major concerning symptoms we talked about, I'm sorry. So the standard assessment of concussion is often performed on the field, as Dr. Carter mentioned. It can be done in the office as well. Dr. Van Buskirk devotes a lot of time and resources to that, and it has very high sensitivity for detecting it. I wanted to talk about the best, you've heard about this a couple of times, and let me just play this video briefly here.
We're going to be testing your balance today according to the BEST test, which is the Balance Error Scoring System test. We're going to be testing your balance on two surfaces, a firm surface and a foam surface. And I will tell you the exact positions I want you to hold, and I'm going to read the script to have it accurate for standardization. Okay? So the first test position is the double leg stance position. You're going to assume the position with your feet together and your arms on your hips. I'm going to be timing you with your eyes closed and see if you can maintain that position for 20 seconds. Okay? So close your eyes, and here we go.
You can see here the first part, which is the double leg stance, and then there's going to be a single leg stance on the non-dominant leg.
The next position is
and
the
then
single leg stance on the firm surface as well, and you're going to choose your non-dominant leg. That's the leg that you do not kick a ball with. So which leg would you kick a ball with? So you're going to be standing on your left leg in this position with your eyes closed. If you should lose your balance in this position, I want you to resume the position and then close your eyes, and I'll tell you when to open your eyes. Okay? Close your eyes now.
And then this goes on to get onto they do the tandem, and then it goes on to demonstrate the getting on the pad,
Do the same thing.
which makes things more difficult.
Three positions that we just did. So you're going to have your feet together, your hands on your hips. And again, we're going to do it for 20 seconds with your eyes closed. If you should lose your balance, I want you to regain your balance and continue with trying to keep stability until I tell you to stop. Okay? Close your eyes now.
that's the tandem, much more difficult on the and each one of those steps off is graded down.
And stop. Thank you so much for doing the best test for me. Thanks for helping me.
So I have to tell you about these two individuals. On the left there is Leanne Robata, and on the right is Rebecca Askew. They're both physical therapists that work in our Balance Center at Scripps. I would not be here today without them because they both saved my life in the ocean about 2 years ago when I mistakenly decided that I would try to surf, and for the first time in big waves. So they were great, and they're expert surfers, and I owe my life to them, actually. And thank you for doing this for us today. Graded symptom scale checklist is another thing that can be very useful, and all this will be in the slides when you get them over the internet. These are all the different symptoms that one can get, and you can grade them from 0 to 6, and can be used to guide you as the patient improves or changes over time. When you combine the SAC, the BESS, and the graded symptom checklist, you have something that's very easily deployable on the sideline. You have immediate objective information. You can use it in combination with other things, and it's very sensitive for diagnosing and tracking. It's a lot to do, but if you have the system set up to be able to do that, like a physician assistant or nurse practitioner or somebody like that, or a therapist can do a lot of these things as well. And you can actually get some good information and track the patient. So the American Academy of Neurology in 2010 came out with a position statement regarding concussive injuries. You may have seen this, but any athlete that was suspected of having a concussion should be removed from participation in play and should not return to play that day. Any concussive event at all. It could be mild, could be more moderate or more severe. They should not return. They're out for the day. No athlete should be allowed to return to play if they are still experiencing symptoms. And a doctor who knows something about concussion should evaluate that patient to give clearance. Now that we talked about earlier, we have the Fresno syndrome where there is nobody out there that can do that, apparently. But we know that there are. We know that there are. And so you have to get that student athlete back to the right docket. Primary care physician, neurologist, physiatrist, any of those that can actually look at this objectively and say, you know, this is okay to start thinking to get back. Now, you don't just go back. And this is another common mistake that the primary cares, even neurologists and physical medicine specialists can make. And it's my humble opinion that my colleagues in neurology actually know very little about concussion and how to return to play, especially in concussion. And you have to have been educated to do this. So it's very important in regards to neurological programs and residency programs now where this is part of the curriculum, that they need to learn this so that the new crop of docs coming out are hopefully going to be much better educated than us old geezers. And so a certified athletic trainer is felt to be somebody who should be at every game and who should be participating. And that communication between the doctor and the athletic trainer, critical in making the right decisions for that student athlete. Financially, that's very tough for schools today. And it's a wish, and hopefully it can come true, but it's tough. And then education aspects need to be brought forth to trainers, coaches, team physicians, as well as school nurses, as well as the physicians, including the students and the parents themselves. And when we've noticed this ourselves, we went through a period of training the high school athletes in our region a few years ago. And what started happening was the students started reporting other students that they weren't doing well and that there was something wrong. And so it actually is helpful to get that down to the athletic level because they will try to cooperate. So the cornerstones of management are that physical and cognitive rest, no same-day return to play, and then this graded program of exertion prior to medical clearance. We need a lot more research to talk about the outcomes of rest. I talked about that pediatric paper earlier today. It's not clear just how much or what form of rest is ultimately going to be the right thing, and it's probably going to end up being individualized to each patient. A low level of exercise may be of some benefit. We just don't know. So return to play. Very important not to return to play, as I mentioned, while still exhibiting symptoms. And it shouldn't really only focus on physical demands, but also on the cognitive issues. And another nice saying here that I like is you really should return to learn before you return to play. And so getting back in classes but not being involved in PE or play in sport may be okay. And you want to support that student from a level of their education. That's the key. And then return to play may follow. You know, if you take a student athlete and you have them go back to class, and even with accommodation, and they report, I can only be in class for 2 or 3 hours, and then my headaches come back, and I get wobbly, that patient is not ready. And you need to back off perhaps a little bit, and then reapproach as they recover. So the presence or recurrence of these symptoms, like I said, are a sign that they're not ready. So how do you return them to play? And there's a variety of stages that you can go to. So you want that first stage to be, at least for a few days, maybe up to a week or 10 days, that complete physical and cognitive rest. Then, when you feel like the student athlete has really gotten back to normal, and you may do this in a couple of ways. You may examine them in the office and make sure that their balance is good, do a modified BEST like they do on the field for the NFL, and see that their balance is okay. You may ask them a few cognitive questions, or if you have the ability to do this, you may actually do these computerized cognitive tests. And if they've had, for instance, like impact testing, if they've had impact testing pre-season, or even if they haven't, you could order impact testing, get that read, and look at either their baseline testing as to where they are now, have they recovered from a cognitive perspective, or how do they compare to norms of their age if they haven't been tested previously. And then use that judgment along with everything else you know and hear about the patient and see in their exam to make a decision, yes, maybe I'm ready to do some light aerobic exercise. So that would be the next phase, light aerobic exercises. Something that actually increases the heart rate. So I'll often ask the patient, get down, give me 20 push-ups, or run in place, or go and run around the office for a few minutes, and then come back, make sure their heart rate's up. How are you feeling? Are you having any headaches? Do a little bit of balance testing at that point, see how they're doing. If they pass through that, then you can have them back to sports-specific exercise. So that could be drills. And now if I'm Dr. Bennett Omalu, I say to them, never go back to play football, never go back to play ice hockey or soccer or whatever. But are they going to listen to that in our culture today? The answer is no. So you get them back to the sport-specific exercise, you have them do some drills but no contact. And if they continue to do well and they're not reporting symptoms, and you don't observe, that is the trainer or the coach, don't observe them to be wobbly or change or complain during that, then you may be ready for the next phase, which is non-contact training where you progress to more complex training exercises, and you increase the cognitive load and have them do sequences and various passes and look at how they execute a play and so forth. And then if that's okay, then you go to full contact practice. At that time, the coach and the trainer need to watch that patient to make sure that they're actually functioning to the same level of ability that they had prior to the concussion. And then if that's okay, then you have some confidence and you can then return to play. And so I don't have any data as to how many people actually follow this. We recommend it, and I'm hoping that people in schools are actually following this, but I actually don't know whether they cut steps or just move right to the edge and try things again. So what is that difficult patient? Dr. Baser really referenced that quite well. That persistent symptom, maybe greater than 10 days, up to as much as 30, 60 days. And general symptoms are not specific to concussion, so it could be a number of things. It could be depression, it could be anxiety, it could be that they have something else going on metabolically. And so you need to do a little bit of thinking about, could there be something else that I'm missing going on? And then that management by the team, that interdisciplinary provider team, gives you the best bang for the buck ultimately in getting them back to normal. There's a whole list of concussion modifiers that make things more difficult: prolonged loss of consciousness, excessive number of concussions, age, younger, takes longer, history of depression or mental illness, ADD, ADHD, things like that, that make things more difficult for that particular individual, which might make things longer, and you need to be more patient with them. So Mike showed you this acute concussion evaluation form. This is available off the CDC website. It is free. It is not proprietary. I do like it in my office. What it does is it gives you a baseline that you can work from. Then you can give this to the patient to bring back to the school nurse or the trainer so that they have something from you that you have communicated to them. And then in addition to that, you can give them the care plan. This is how you actually should proceed with return to play when it's appropriate. You can check off the various things. The red flags are on there. These are excellent tools. They're free, and they work really well and can become part of your medical record. I want to just briefly mention second impact syndrome. Fortunately, this is a very rare syndrome. I've seen in my career only, and I do brain injury, a lot of brain injury, only 1 or 2 cases. It's extremely rare. And they say there's only been 35 probable cases identified in a 23-year period in the United States. That's probably higher than that number. But it's poorly understood. And what's interesting about it is that it really primarily occurs in adolescents and very young adults. And we think it's due to the fact that their ability to auto-regulate that blood flow has not yet matured to its full capability. So what happens is they have a concussion, and then they don't fully recover, and they're sent back into play. And they can have just a mild hit. It doesn't have to be a major hit. And they collapse. They have sudden massive increase in intracranial pressure. They herniate, and they die in minutes or in an hour or so. And it's super dramatic. So we don't understand why it occurs, but it's limited to this group. And that's why it's so important for us as healthcare professionals to really safeguard that patient. They depend on us for giving them that information that you can't return until you're feeling normal. Because even though these things are rare, they do happen, and they're tragic when they do occur. So the functional outcome is a product of a variety of things. You know, if I am subject to a concussive injury, and I lose some mild short-term memory, and I have some difficulty multitasking and recalling information, I'm out of a job, right? Would you come to me if I had those problems? I don't think so. If you're an airline pilot, if you're a teacher, any one of a number of professions that require a lot of cognitive input, all of you sitting here, it really makes a difference. If you're on the assembly line and you're putting one widget into another, that's a little bit of a different story. So those kinds of individuals that have those kinds of occupations may be able to return sooner and more quick than others. So the context of the injury and how it fits in to that person's personality and life are very critical. The job and home requirements, other medical factors, age. We talked about the young, but in the old, you know, now today we have the silver tsunami coming. Look at me. And my balance isn't what it used to be. I don't think I passed that Berg test. You're not allowed to give me the Berg test or the BEST test. As we age, our balance is worse. The number of head injuries in geriatric age range has skyrocketed. The number of subdurals our neurosurgeons are seeing in the emergency room have skyrocketed. And so all of that fits in. The legal status fits in. Litigation aspects may involve some symptoms or prolongation. The legal system is not designed to reduce stress in an individual. So the stress level goes up, and that may affect symptoms as well. I love this slide. This is a slide from a publication by Jonathan Silver, who spoke at our conference about 3-4 years ago. I usually include this slide in every talk that I give because it really gets to the essence of what's happening here. So on the left side of the slide, you see pre-injury factors, what that patient brings to the party. Depression, anxiety, you know, whether they have ADD or ADHD, whether they have migraines, whether they're normal, or all sorts of things. Then you have the injury itself, and then you also have those post-injury factors that are psychosocial in nature, which can include loss of income, loss of job, inability to go back to school, and so forth. And then in the middle there, you see how all of those things combine. And you have a cognitive disturbance that comes along, an emotional disturbance, a behavioral problem. You have difficulty with physical issues. For instance, you may have headaches or pain from other injuries that are difficult. And then all of that mixes up, and you get a whole host of symptoms on the right side that are all part of this syndrome. I said yesterday, it's never black, it's never white, it's always gray. And this really sums it up. So that's why the interdisciplinary approach with neuropsychology, psychology, therapists that are trained in treating all of this, the doctor treating the pain and guiding this process as much as possible really gives you the best possibility of a good outcome. So what is the rehabilitation process here? It's that goal-directed, enabling, dynamic process of empowering an individual to reach their optimal physical and mental health and cognitive health. I never used to think that I was a holistic doctor until I went into rehab. Rehab is the paradigm of holistic medicine because we treat the whole patient, all aspects. And it's that physical, cognitive, psychosocial, emotional, and cultural. Culture, big issue. Because you're going to, in certain cultures, intervening in one way versus another way may make a huge difference in how that patient responds or approaches you. So we talked about a lot of the treatment options. I'll go quickly. First and foremost is reassurance and observation, early. Later, you start getting into the more complex things that require perhaps referral to a specialist. Cognitive remediation can ultimately occur. I think it's beneficial in most cases where you get speech and language therapy, multidisciplinary coordinated treatment with PT and OT. you know, in our military population, when the war broke out in Iraq, we're positioned right by Camp Pendleton, so we got a lot of patients from Camp Pendleton. And this was early in the war, and they were coming in with both blast injury, mild TBIs, as well as post-traumatic stress disorder. And at first it was sort of hard to tell them apart, and then we got better at that, and we would know when there's bad PTSD, they really went for treatment of that before they got into cognitive remediation, or vice versa. But one of the things we also noticed was that in Marines, young Marines, men and women, physical fitness was par excellence #1, and we had to devise systems where we actually used physical and occupational therapy in a way to help with the cognitive retraining. So one of the things we did, and this is going to sound very antithetical, is we actually did boxing with the Marines. They loved it. They got the mitts on, and the therapist would be there, and this wasn't, you know, like punching in the head or anything like that. But we got the mitts on, and the therapist would give them sequences of punches. First one, left, right, then left, left, right, right, and so forth. And so got them to go through sequencing, which is a frontal lobe kind of training exercise. So this kind of multidisciplinary, clever therapy that our therapists really came up with as we went along was really very helpful, and it kept them engaged in their treatment program. Lots of referrals to consider once things go on 3 to 6 months or more, that 3TMR, the various referrals, and so forth. As far as medications, I really don't want to talk about any specific medications since it's so individual for that particular issue, but there are potential medications that will help. Let me just move through this. We talked about that, physical therapy, Baden-Gallant's, vestibular, OT, all of the things relating to their activities of daily living, and speech therapy, looking at their auditory, verbal comprehension, attention, memory. One of the things we did learn with the military population also was that a lot of the Marines came back and said, I can't hear. And we did audiometry, and they had normal hearing, but yet they would say they can't hear. And it turns out a significant number of them had a new central auditory processing disorder. So that was something we had to adjust to. There's very little information about that now accumulating once again, and that can be helped. So I'm going to stop here. That's my slide from before, but I can stop and take a few questions. We're running about 15, 20 minutes behind schedule, and lunch is ready to go. And in fact, I'll tell you what I'll do. No questions right now, but I'll be right outside and I can talk to anybody that you like. So now, thank you.